cover some of the topics relating to our biopsies, and I'm not going to talk about the diagnostic and therapeutic injections. I will talk about image-guided ablations though at the end. So when we get a request for biopsy of a soft tissue or bone lesion, so we go through this case, and the first question we have to answer is it indicated? Because there's going to be a number of cases, or there are many cases that come to us for biopsy that may not necessarily require it. I can tell you, like PET-positive fractures, especially insufficiency fractures that were shown by Dr. Schweitzer earlier. I've seen several cases that were PET-positive in patients with no malignancy, and they were read as metastatic disease, came for a biopsy, and those are the things that we have to pick up and eliminate before we actually do the biopsy. So the next question we have to answer is, what is the best imaging modality for our guidance? We like to use imaging guidance as opposed to surgeons who would take them to operating room and do a much more extensive procedure compared to a needle-guided needle biopsy. So the next question is whether the referral is coming from an orthopedic oncologist or a primary care physician. Obviously, if it's coming from an orthopedic oncologist, it's a much easier workup, and you know that the patient most likely needs this biopsy. It's a much easier process as opposed to a primary care doctor may not necessarily know exactly what's going on, so you probably would need to scrutinize those patients more than the ones that are referred by orthopedic oncologists. And when we are thinking or planning the approach, especially dealing with a primary neoplasm as opposed to a metastatic one, always discuss that with the surgeon who's going to do the final surgery. We can go through articles or textbooks looking at the planes where we should be contaminated, but ultimately discussing that with the surgeon is the most important thing, because they are the ones who are going to go into that area and excise your needle track, and they will tell you exactly how they want it done. The from imaging modalities, we have ultrasound, CT, and rarely MRI that I will be talking about. So for ultrasound guidance, I'm sure most of you are familiar and comfortable with doing procedures under ultrasound. I think outside the United States, it's probably the most common modality used by many radiologists. And they're excellent for superficial lesions in the soft tissues, and it's cheaper and readily available in many places. And one of the advantages also is the ability to delineate vascular flow. It's shown in this recurrent mass in the posterior thigh in a patient with large amount of hardware. You can see that there's a central area of anechoic region. When you turn on the blood flow, this is the blood vessel. It's encased by the mass, so we can easily see this while we're biopsying, so it makes our life much more easier. It's also very helpful in patients who have a lot of postoperative metal that might prevent them getting a decent CT-guided biopsy where you will see a lot of artifacts. In our institution, we use CT more than any other imaging modality for our biopsies of both soft tissue and bone lesions. One of the reasons is that I think most of us feel very comfortable using the scanner and having all of our setup there, as opposed to ultrasound, where we feel less comfortable, with the exception of very superficial cases. I think CT is very helpful, especially when we're dealing with deep lesions. Of course, there are problems. The soft tissue contrast resolution is not that great, because when you're dealing with a mass, most of the time it's surrounded by muscle, and their density is very similar, so it's very difficult to separate them. It's much more expensive and obviously involves ionizing radiation, which is becoming an important topic in the recent years to try and limit the amount of radiation patients are exposed to. I just want to show an example. This is a patient with recurrent myxoid liposarcoma in the thigh. You can see the evidence of prior surgery with surgical clips, and this is the MRI showing this recurring mass that's enhancing this post-contrast T1 weighted fast image. When we did the CT before the biopsy, it was very difficult to see. Essentially, you can't see anything in that region where you see the soft tissue mass easily. So when you give contrast, sometimes it helps that area actually showed up very nicely before we stick the needle and biopsy that, confirming that that was actually a recurrent liposarcoma. When we're doing bone biopsies, again, CT is the most frequently utilized modality, and it's very helpful for planning, looking at the length of the needle, the amount of tissues you have to go through before you stick the needle. We don't do fluoroscopy guided biopsies, and I know that there are some places in the US that are still doing fluoroscopy guided biopsies, but I personally don't feel very comfortable because of 2D imaging where you might be injuring certain tissues without knowing what's happening. And also our setup of the nurses, we have everything available at the CT scanner as opposed to carrying stuff over to fluoroscopy suite where we're not really doing procedures on a regular basis except joint injections. And MR guidance is rarely required. So when we're doing CT guided biopsies, it gives us very good anatomical detail in the bone because the cortex and the medullary cavity, you can separate them. Sometimes subtle narrow changes may not easily be seen, and this is an example that I will use. This is a picture from our CT scanner. It's a CT fluoroscopy unit, and in some cases, such as this one, a patient with suspected breast metastases, it shows up beautifully on T1 weighted image. Again, it's darker than muscle, but on CT it's very difficult to see. So sometimes it helps to put those images side by side, and our scanner allows us to put that on the scanner at the time of the biopsy to help us with the anatomical landmarks, so we can actually go up to that area and biopsy real time. It's almost like a blind biopsy, but essentially you can see the landmarks, and it helps you to localize your biopsy location. While doing the biopsy, I think it's helpful to avoid the joints and neurovascular structures that are usually seen really well on CT images. This is a recent case. I just wanted to show this as an example for planning. This is a patient with a lesion in the acetabulum with convoluted pinion matrix. And in addition to that, there's a large hernia in the inguinal region. So this doesn't leave us with very much window. We have the joint here. We wouldn't be able to go through the anterior soft tissue because this is a primary lesion, and we would like this patient to have the best shot after the biopsy to get this resected, and it hasn't broken into the soft tissues yet. And the best approach, we decided, talking to the surgeon, is to go to the superior margin of this lesion where it's not the bulk of the lesion. Even though it doesn't seem to be the ideal location, we went through the top of the lesion where it was confirmed to be a chondrosarcoma. And in most cases, unfortunately, the shortest distance or the easiest one is not the best approach for the patient and for surgical planning. MR-guided biopsies are done in very few centers around the world, and there's a reason for this. most of our biopsies are sufficiently done with CT and ultrasound or a combination of those imaging modalities. MR-guided biopsies are very expensive because we're consuming a long time in the scanner. Also, the needles and all the devices we use are much more expensive than CT guidance. So we have to decide whether it's really necessary. This is an example of a patient. I will show the images during this biopsy. You can see that there is a lesion in the iliac crest. Patient came in with suspicion of metastatic disease. It was worked up in an outside institution, even though there were many lesions on the MRI. Nothing was seen on the CT scanner, and this is an image from the outside biopsy where they did a blind biopsy of one of the large lesions, thinking that they would be in the neighborhood. But that turned out to be non-diagnostic, so patient came to our institution, and we decided to do this biopsy under MR guidance. This is just to show that the largest lesion I marked here, and this is just a marker that we did with some fish oil tablets that we put on the patient to help us localize this lesion. And using this needle, we went after that large lesion. And this is a post-biopsy coronal scoring image showing that large lesion, and those are two of my biopsy tracts, and another lesion in this location. And this turned out to be a patient with sarcoma who didn't have any pulmonary manifestations, and the only problem she had was these bone lesions, and she didn't have any other disease elsewhere. Again, the MR-guided biopsies should be reserved to very few patients for all those reasons, spending all that time and money, whether it's worth it. In the next 15 to 20 minutes, I would like to talk about the image-guided treatment that are done nowadays to treat many of the musculoskeletal lesions. The most commonly used methods are radiofrequency ablation or microwave ablation, very similar way of working, and cryoablation, where there's freezing of the tissues. So when do we perform these procedures? I think painful metastases are probably the most common indication, and osteoblast has been proven to be treated with radiofrequency ablation, which became the standard of treatment in the last 20 years or so. But there are other bone tumors reported in the literature to be treated with radiofrequency ablation, like chondroblastomas and phosphaturic mesenchymal tumors. And soft tissue tumors like desmos can also be treated with these methods. I'd like to talk about the METs for a few minutes. Well, autopsy studies have shown that up to 85% of patients dying from breast, prostate, or lung cancers have bone mets at the time of the death. That number might even be higher, considering how frequently we see these mets from those particular tumors. Complications due to skeletal metastases were elaborated by Dr. Schweitzer, and they can often really affect the patient's quality of life and shorten the life expectancy because of the fractures and other complications. And in addition to reducing patients' life expectancy, it also affects the quality of life in these patients. And they can end up with depression and anxiety in the last few remaining months of their lives. And the presence of pain is not really correlated with the type of the tumor, location, or even the number or size of the metastases, which is very interesting, because I used to think that if there's a really large tumor, it's more likely to be associated with pain, but the reality is it's not correct. There might be very small lesion that might be giving pain, as opposed to a very large destructive lesion that might be more silent. Why do these patients have pain? And I think it's very important to understand this before treating them. Most likely etiology is the stretching of the periosteum secondary to tumor expansion. So knowing this, it's going to be important during the ablation procedure to go after that area that's causing the pain. You can also have fractures. There are both microfractures or trabecular fractures or obvious microscopic fracture lines that might be visible. There's also other reasons why these patients might be having pain because of the osteoclastic bone destruction. There might be some mediators going into the bloodstream, stimulating the nerve ends and the endosteum of these patients. Also, the tumor infiltration into the periosseous nerves and tissue could be implicated for pain in these patients. And another thing we have to understand talking to these patients is these are palliative methods, and they're not going to cure these patients. Buy them more time and improve their pain in the last few months or years of their life. Obviously, there are other methods of therapies, radiation and surgery. In addition to the systemic therapies like chemotherapy, hormonal therapy, depending on the type of the tumor, also certain radiopharmaceuticals and bisphosphonates, as Dr. Schweitzer explained, that might be helpful in these patients who have bone mets. You can also use a number of analgesics, corticosteroids, and NSAIDs to help in the treatment of these patients for pain control. Right now, the center of care for cancer patients present with localized bone pain from metastatic disease to get external beam radiation therapy. And it's usually very helpful, and patients experience a reduction in their pain, at least most of them. Although 20 to 30% of these patients may not experience pain relief completely. So when we're selecting patients for ablation treatment, we have to make sure that patients actually have moderate to severe pain, at least 4 out of 10, because treating a lesion that's not painful can give you a headache because it might become painful after you treat them because of the procedure itself. And also, I think it's helpful to treat patients when their pain is limited to 1 or 2 sites. If they have pain all over their body, we would be able to help them, and it might complicate the situation by trying to treat certain areas as opposed to, we wouldn't be able to treat the entire body or more than a few locations at a time. And looking at the imaging study is very important to find the corresponding abnormality where the patients have pain, whether it's a CT or MRI. And we have to determine what kind of lesion we're dealing with, whether it's lytic, sclerotic, or whether there's a soft tissue mass associated with these lesions. And I would say that most of them do have soft tissue mass associated with these painful metastatic lesions. And we have to assess the risk of fracturing a weight-bearing long bone. It might be a really complicated procedure to do an ablation in lower extremities. Most of these patients go through these procedures under general anesthesia. Some occasionally may get conscious sedation. I think regional anesthesia is a difficult thing to do for these procedures. In terms of imaging guidance, some places do try using ultrasound, but in our institution we are very comfortable using CT guidance for these ablation procedures, as I explained earlier. For RFA technique, I think for Most of these tumors, we try to place the needle inside the lesion, and depending on the size of the lesion and the type of the tumor we're dealing with, we do an ablation of 5 to 15 minutes. And if a lesion is less than 3 centimeters, and single ablation is often enough. For larger tumors, we can do multiple ablations. Here's an example of actually the youngest patient I treated for metastatic disease. This was a 19-year-old, was neuroblastoma, multiple bone lesions, and these are very painful. In the chest cavity, he was having difficulty taking a deep breath. This is our needle in the region of the destructive lesion around the rib, giving patients pain. You can see that it's the edges of the destroyed ribs. And we treated this patient with radiofrequency ablation. In the pelvic area, when we do the radiofrequency ablation, we can also combine this with cementoplasty. This is a patient with breast cancer, and can appreciate this big destructive lesion in the acetabulum. After performing the radiofrequency ablation, this is our probe inside the lesion, and these are small foci of gas that are introduced during the ablation procedure. Once we remove this needle, we place some metalmetabolate that would create some support in the area where we do the ablation, because this is a weight-bearing area where the patient is walking after the procedure when the pain is getting better. So it's important to achieve that structural stability by introducing some metalmetabolate. One thing that we have to be very careful about is to make sure that there's no extension into the joint, which might be a problem if there's leakage of metalmetabolate that would be limiting the patient's movement. This is after the introduction of the metalmetabolate. You can see the track of our needle. This patient actually lived for about a year after this procedure and was able to walk comfortably up until the last few days of her life. When we look at the results of the radiofrequency ablation for metastatic disease, 95% of patients have clinically significant decrease in pain, at least 2 points or more in a 24-hour period after these procedures are done. Of course, in this trial, there were complications in 6.5% patients. And these complications include some tumor cutaneous fistulas, because we were essentially going with a needle into the tumor and then pulling that needle out. These patients can also get pathologic fracture because there's a bone that's already weakened by tumor, and we're weakening it further with ablation. And there are other potential complications. You can have neurovascular damage, skin burns, and cartilage damage if it's being done near a joint. Cryotherapy gained popularity after the introduction of RFA. Nowadays, I think most big centers around the world are choosing cryotherapy over RFA for treatment of bone lesions. The technique itself is very similar, placing the needle tip inside the lesion. The only difference is most of these cases are done with multiple needles at once, as opposed to having 1 or 2 needles for radiofrequency ablation. This patient is having 4 needles at once. These are typically probes that are hollow metallic tubes. Can have either gas or liquid cryogen that flows, and water in the tissue freezes and forms an ice ball, and it's very easy to follow the ice ball, the size under the CT guidance as we are performing the procedure. This is just to show how the ice ball forms around the tip of the needle. This technique is actually nothing new. The surgeons had used this for a while, and for a variety of tumors in the liver, prostate, and other locations. I think what happened recently was the needles became smaller and easier to use for us to use them under imaging guidance. That's why it's becoming more popular to use it in radiology suites nowadays, as opposed to traditionally using the operating room. These are the first generation large needles, and you can appreciate the difference in the size of these lesions that we use, of the needles we use nowadays for the cryoablation. One of the advantages of cryoablation over radiofrequency ablation is the patient's pain level. Radiofrequency ablations tend to be much more painful. That's why they should be done under general anesthesia. Cryoablation tends to be less painful and could be performed under conscious sedation without significant pain reported by the patients during the procedure. And in terms of technique, in the literature, it's been recommended that you could place needles that are about 2 centimeters from each other and during the ablation, forming an ice bowl. Here's one of my cases that I've done last year. This is the proximal humerus. There was a lytic destructive lesion of the inferior glenoid with an associated soft tissue mass. This is a patient with known lung cancer. Is having intractable shoulder pain, was 8 to 9 out of 10 despite the use of narcotics. You can see these 3 needles forming this round ice ball. It was almost like a tubular area of freezing, and this patient actually went back to close to normal without requiring any opioid analgesics after the procedure, and he's still alive after a year. People use other modalities for guidance. MRI would be ideal, although again, it's very difficult to do them for a variety of reasons, mostly because of monitoring issues and the time. And ultrasound is very difficult to monitor, considering the surrounding structures. CT would be ideal to do for most of these cases. And the needles are, again, placed under CT guidance into this scapular lesion. As you can see, these are large needles, but it's not different than placing a biopsy needle, essentially going after the lesion that you'd like to treat. And this is a paper that describes the complications after cryoablation. And there's a number of different things: nerve damage, fractures. As I was saying earlier, the bone is already weakened, so introducing a cryoablation or radiofrequency ablation further weakens the bone, helping or inducing a fracture in these patients. So we have to be very careful treating lower extremity bones. These are much easier to use in the pelvis and in the flat bones like scapula, where a fracture is not as critical or important as lower extremity, especially in the femur. Again, when we look at the results of cryoablation, they're very comparable to RFA. The vast majority of these patients have reported a significant drop in their worst pain after the procedure. But the question is which one to do, like whether you should burn them or freeze them, these metastatic lesions. Looking at the results side by side, RFA and cryoablation, they have very comparable and very good results in pain control. But for the reasons I was mentioning earlier, RFA requires general anesthesia as opposed to performing cryoablation under moderate conscious sedation, because these patients are pretty sick. They have widespread metastatic disease, they have cancer, they're elderly. So if you can avoid performing these under general anesthesia, we should definitely try and do that for morbidity and mortality reasons. Again, it's very difficult to assess the size of ablation during radiofrequency ablation. You always predict what's been recommended by the vendors, but depending on the tissue quality, whether it's bone, soft tissue, or a combination, there could be an unpredictable area, whether it's larger or smaller area of ablation. But for cryoablation, you can easily visualize the enlargement of the ice ball under CT guidance periodically as you are performing these procedures. Again, complications, they both have their complications. Obviously, nothing is risk-free, especially for a procedure like this. You can have pathologic fractures, tumor cutaneous fistulas, nerve damage, and cartilage damage if it's near a joint. And my feeling is cryoablation is probably better than radiofrequency ablation for cartilage damage. And even for nerve damage, some people believe that cryotherapy is probably better, and those nerves are more likely to recover after the procedure as opposed to radiofrequency ablation when when there's a burn of a nerve that never comes back. So in conclusion, RFA and cryoablation have been proven to be very effective treatment options in treating these patients who are suffering from pain, who are not responding to radiation. So I think it's helpful to do more and more of these procedures as the new techniques, chemotherapy, evolve. I think more and more patients with metastatic patients are living longer, and if you can help them control their pain, this would be a great thing to do. I also would like to spend a few minutes talking about other indications for radiofrequency ablation. These are great procedures because they're done in younger kids who are otherwise healthy, miserable. We do these procedures, they're completely cured, and their pain is gone, everybody's happy, as opposed to the metastatic disease patients that are elderly, like that they're going to be dying within months, if not sometimes weeks. So these are much more fun to do. These patients typically are younger, either kids or young adults, and they come in with pain, worse at night, and relieved by NSAIDs. And ever since Dr. Rosenthal from MGH introduced this method to treat these lesions in the 1980s, they became standard of care for treatment of these patients with success rate that's close to 100%, very comparable to surgical methods. Here's an example. This is a high school student who was a very competitive skier and had this MR, and initially they thought because he was so active and constantly exercising that this might be stress reaction or developing fracture. They told him to rest his leg. After a few months, he wasn't getting better, and got another MR, still shows that area. On the axial image, you can sort of see that there might be a little nidus, and here it is. It's probably the smallest nidus I've seen, and this was a debate whether we should be going after this area or whether it could be something else. And I decided to go after this and biopsy this, and almost half of my biopsies come back as negative, especially for small lesions when the nidus is very difficult to see. But luckily on this one, we got the pathology proof that this was actually an osseous and this kid's pain was completely gone. Here on this image, you can see my needle inside the joint. I think some of you might think that I ended up in the wrong location, but it wasn't the case. I injected cold saline before performing this procedure to prevent the cartilage getting burned from the procedure during the ablation. I have also done soft tissue ablations for desmoids. As you all know, desmoids are aggressive soft tissue tumors. Even though they're considered benign, in many ways they are very malignant. Recurrence after the surgical resection is almost inevitable, and they're very unpredictable tumors. Here is a high school athlete who fell and went to the doctor thinking that she might be feeling a hematoma, and they got this MRI showing this large area. Initially they weren't sure whether this could be hematoma given the recent injury, but when we look, you can see that it really doesn't look like a hematoma, and the post-contrast images, there was intralesional enhancement, which may or may not be seen with desmoids. Some cellular lesions are likely to enhance as opposed to some acellular ones that may not enhance. And this is the RFA needle in several different locations within this mass. So this is the pre-procedural MRI, and this is the follow-up MR showing a larger area of ablation. And this patient didn't have any recurrence in that area, and it was completely cured. I think this is the last slide.